What's going on, everybody? It is Mark Cargill, the lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you with another episode around lower extremity neurodynamics in the Modern Pain podcast. Gosh, I think we're up to like 50-something episodes at this point. Finally getting a little bit more consistent publishing schedule. And I hope if you guys are enjoying these episodes, jump on and rate and review on Apple Podcasts and any of your podcast platforms. That just helps us get a little bit better reach and hopefully help some more clinicians if they're struggling with some of these things. We talked about dosing, and like last episode, we're going to talk about dosing, and then of course, per usual, Jarod and I get on regular little tangents, and then we finish the episode. You know what? We didn't really talk about dosing all that much as we'd like to. So we're going to talk about that this episode. But let's welcome in our co-host, Jarod Hall. How are you doing?
Doing fantastic this morning, Mark. Was dealing with a little bit of allergy stuff. Still got, a drainage going on, but I really tried to clear my throat out today. So let's see how we sound.
Yeah, Jared's just battling. He's hitting the mute on the mic. I can see if you're watching on the video on YouTube or on anywhere else of our video podcast. The man's soldiering through the lovely allergy season that begins. I was just telling him that Arizona, it's about that time. We're blooming and wind blowing and green dust everywhere where my allergies go bonkers. So we're hopefully going to keep the podcast not derailed from lovely allergies. But Jared's soldiering on, and we appreciate it. So Jarod, the dosing thing, because I do think this is a definitive issue with students kind of reasoning through it, because there's always these generic dosing schemes in research studies that just dose to a consistent, internally valid way of looking at dosing, which kind of strips the clinical reasoning and thinking out of dosing. Because everything you read in manual therapy literature, 3 bouts of 30 seconds was pretty much everything from a usual mobilization and sometimes stretching perspective. Yet there's probably some nuance in the clinic that we should be looking at as far as dosing to the unique person in front of you, and not dosing to what, this randomized control trial said that it should be dosed. I mean, of course, we're going to use those things as possible influencing factors of what makes us think about how we're going to dose, but probably need to get a little bit more nuanced and specific to the person. But what's your thoughts around dosing when it comes to neurodynamics?
My thoughts around dosing when it comes to all of our treatments, all of our exercise, all of our techniques, I think that dosing is probably one of the most overlooked but most important factors of what we do. And I don't want to say that it's more important than specific exercise, but I kind of feel like it's more important than specific exercise. Of course, there's nuance to that. But, when we think about exercise in general, dosing should occur with a specific goal in mind. Is that goal to create power? Is that goal strength? Is that goal endurance? Is that goal hypertrophy? Is that goal, just gradual increase in volume over time in graded progression of exercise? Or is that dose more of a graded exposure type dose where it's time spent in an exercise with active reflection and fear confrontation and all this sort of stuff, right? So you can think about dosing in so many different ways, but
hold on a second. You're good. I think we just blinked a little bit, but continue on, man. This is, if we edit it, we edit it. Otherwise, you guys just saw the lovely tech gremlins do their thing.
Yeah, that was strange. So there's so many different ways to think about dosing, and I think most of the time we're thinking about dosing from a standpoint of what is it doing to kind of muscles and more other connective tissues like cartilage and bone and that sort of thing. And I think that when we think about dosing for neural tissue, it's really similar in some ways, but I also think that it's different in some ways. And if I'm going to do dosing for somebody that seems to have some sort of neurodynamic issue, neuropathy type issue, the first thing I have to think about is, how irritable is this structure? And I think about loading nerves, doing things like nerve glides, nerve tensioners, or whatever it is. I don't think about the nerve moving. I don't think about sliding and gliding. I don't think that we can say that a nerve is trapped with a clinical assessment. I don't think that we can say that its ability to move and its excursion is impaired. What I think that we can say is it is a certain degree of tolerant to a certain degree of load, right? Both an intensity of load and a volume of load. So how hard do I stretch it, and how many times do I stretch it? So I think that we need to get away from this whole thought process of sliders and gliders versus tensioners and just start thinking about, I am loading a nerve with a certain intensity and a certain volume. And that really comes down to the irritability. If it's highly irritable, then I'm probably going to lean towards a low intensity of load and probably start with a lower volume with more rest, with more spread out, maybe 2 or 3 or 4 or 5 reps at a time at a really low intensity. Whereas I have somebody that's not very irritable, well, then I might intensify my load, right? So I might do more of the tensioner type approach. I might allow them to stretch it a lot. I might allow them to really go into their in-range positions where they feel like they're getting a good tug on the nerve. And then I might increase the volume as well. I might do 10 or 12 or 15 reps at a time, and maybe come back to this once every hour or whatever it is. And we have to figure out, based on the irritability of that particular person at that particular time, a dose that we think is sufficient to cause a positive, impact, but not excessive to where it causes exacerbation. And for some people, that window is going to be very, very small, and some people that window is going to be very, very big. And that's where this nuance of dosing for individual people comes in, and why it's so important to do the things that we talked about in the previous neurodynamic episodes on, assessing the severity, assessing the irritability, assessing, different positions and movements that might exacerbate it, testing in their irritable versus non-irritable positions and all of that sort of stuff. What do you think, Mark?
No, I definitely am on board. I like the thoughts of getting away from this hyper mechanical specific, I can identify where a nerve's entrapped. I don't think it's a fruitful pursuit, just because I don't think we have any evidence that we can. I'm sure there's some gurus out there saying they can palpate pennies through, city phone books and all those different things. But I think, just, load and volume. But and that's where I talk to the students, is like, this is just, we're testing that neural tract sensitivity to putting mechanical load on it, and looking at that symptom behavior of the patient and understanding that they've already told us that it doesn't take much load and much to bring it on, that we probably should start at that lower intensity, lower volume aspect. We can always increase the dose, but once you blast past the tolerance, now you're working, especially on an irritable patient, where we often are going to have symptoms that linger more than you can really compromise your rest of your session if you start really overdoing it early on in a session, where now symptoms are ticked off. Now everything you do hurts, and it's hard to really determine. We always say you don't get clean data because you got just an irritable, aggravated condition that, and we've all had those patients in clinic where it's hard for me to figure anything out right now. You're just in so much pain. We got to just let's calm it down so we can start getting good data with you. And granted, I've had patients where in session we overdid it, and despite best efforts and understanding all these factors. But I think the more kind of purposeful, reflective ways of practicing, where you're thinking about these things as you're applying, versus I do neurodynamics on everybody and this is what I do. I think that's definitely the better way, the more patient-centered way to get after neurodynamics. The other thing I think you talked about that I think is greatly underappreciated is that there's a psychological load, cognitive load that accompanies this stuff with it, not just neurodynamics, with any exercise. And that's where understanding, hey patient, what do you think about doing some of these regular movements into some of these sensitive ranges for you? Here's my thought process of why I think we need to just, this tissue sensitive. We're going to start doing some gentle, movements to see if we can start stimulating some load through that sensitivity, with the goal of decreasing it, because your body starts doing what human bodies do if we can design a load that works for you. But again, if that load is accompanied by a catastrophizing, fearful system that's attached to that load, it's not going to probably go well. But that's where, what do you think about that? What are your thoughts around doing this? Is this something you think would be helpful for you? Are you willing to do this? And just those simple things that you can add into your exercises and your dosing, one gets you like, holy cow, this person's not on board even a little bit with doing that. Then you need to step back and you need to at least either explain things better, or maybe you do. Maybe even though you think the patient's there, you're not going to go there day one because that's like a 10 on their fear meter. We need to bring it down to a dose of maybe a position or a load or whatever it may be, or combinations of all that stuff to find an entry point for that patient. Because I think there's too often we look at biomechanical studies and of like, this is the exact newtons that needs to be applied, yet that person's unique human experience and perceptions and cognitions around what's going on isn't brought into that equation. So that's where the skill and the nuance comes in when it comes to dosing too. So yeah, what are your thoughts around, because I think, you hear Iones's group and others talk about cognition targeted exercise and things like that. How much are like cognition targeted dosing and patient targeted dosing from a more of that psychological cognitive load factors are you bringing into the game, Jarod?
I mean, it's a constant dialogue. Like, are you, I'll often ask people, like, how do you feel about this specific exercise? Is this something that you're on board with? Is this something that you feel like you can do? How does this exercise fit into your daily life? Is it something that does it concern you? Do you think that something negative is going on during this exercise? Do you have this vision of like a disc herniation in your neck, just like pinching the hell out of a nerve, and I'm asking you to pull on this nerve, and you're thinking that it's getting sheared in half in somewhere in your neck or somewhere in your low back? Like, what is going on in that person's mind? What do they think that exercise is causing to happen, for one? How fearful or non-fearful are they of that exercise? For two, let's talk about exercise adherence. Your perfect dosing doesn't freaking matter if a person's not going to do it, right? So, like, hey, I want you to do 7.5 median nerve tensioners every 45 minutes throughout the day, because this is going to lead to the optimum dose, in a 24-hour period. It's like, well, that doesn't work with their life. So you're not going to get that. It doesn't, it doesn't matter. It doesn't work. You have to ask people, hey, can you help me find a frequency or a dose level or a volume of exercise that you feel like is no problem for you to manage, that you can do and achieve, and it will fit with your particular lifestyle, right? So to me, figuring out exercise adherence is cognitively targeted exercise as well, because you're not just throwing a prescription at people and like hoping it sticks. You're entering into an active, engaging conversation with them to agree upon an exercise that they feel like they can do. And guess what? When people say, yeah, that's something I can do, we worked on this together, we've had some shared decision making, I'm agreeing to it, they're a heck of a lot more likely to be adherent to that exercise program. And this is another little trick that I like to do. I don't want to call it a trick, but this is something that came up in our Complete Clinician Supercharged mentorship the other day. We were talking about getting people to do their home exercises. And at that point, when we've entered into that shared decision making for a home exercise program at a specific dose, I will put my hand out and ask the patient to shake my hand and say, all right, let's shake on it. This is an agreement that we're entering into. Like, I'm holding up my end of the bargain. I need you to hold up your end of the bargain. And this might seem silly, but we as human beings have a little bit of value for our word, for our trust, for a commitment that we give to another human being, right? It's the concept of a little bit of reciprocal altruism, where, somebody else, you do something good for somebody else and that they do something good back for you. It's like, well, you enter into this contract and you shake on it like it's a real bond, right? And maybe that's because I'm in the South in the United States. I don't know. But when you shake on something, it is very serious. Like, you have to hold up that end of the bargain. And I haven't done anything negative for this person. I've just made that agreement real to them, and hopefully made them, have just a little bit of extra, like, man, I really need to stick to that. I shook Jarod's hand, and I told him I was gonna stick to it as well. And that, like I said, that might seem silly, but it has been tremendously effective in my clinical practice to just make, like, verbal and contracts with people after a shared decision-making process that we both agree on.
Strangely, our colleagues in Washington, D.C. said this does not work in their neck of the woods, in their population. It just hasn't been able. I was just hanging on that, waiting to throw it in there. But yeah, no, I think it definitely, I think you're talking about incorporating yourself into somebody's culture, their social context. And that's where you bring that patient's context of what's their life look like outside this room. Instead of like, oh, I need to do, like you said, this is the optimal dose this study says, and I'm gonna give you a specific schedule throughout the day that you must do if you're gonna get the optimal dose. Versus, hey, patient, like you said, you have that conversation. What's your life look like? What do you think is reasonable for you to be able to start getting after this a little bit? Because I'm not interested. Would you agree with me? And I'll have patients like, do you think not doing anything is going to cause this thing to change? And especially if you showed some retest, like, hey, we did some things that showed us moving you in a good direction with this. Do you think that would be beneficial to do away from here? Ideally, yes. Well, then let's find a schedule for you that works for you, because I will say it's already proven to us that it's a worthwhile pursuit to start getting after this. Let's see if we can give you a schedule that you can do this at home, because my goal is for you to come back in and feel like, hey, I don't even need to come to these therapy guys anymore eventually because I'm doing very well. And so we got to fit this into your life, and I'm not interested in giving you exercises that just collect dust and don't get done, because that ain't going to give you the change you're desiring. So again, I like the entering into a kind of verbal contract with the patient where you're. I do think there's a lot of patients, depends on the patient, I'm sure, but where that becomes a little bit of a more haste. The stakes are raised because I've shook on it. I've made a verbal commitment to this therapist that I got to look him in the eye next time I come in there and answer the question of how'd you do, and we don't like browbeat people. Life happens. Sometimes things don't get done, and now obviously that opens up dialogues if things aren't getting done, and we just for the sake of not being done, then again you start talking about behavior change, and we got to find a way to get you doing it. And having some conversations of like, hey, I want to help you. I'm 100% on this team with you, but I'm not getting the sense that you're on this. What can we do to help you get committed? Because I think we got amazing opportunities to make some big changes for you. You've mentioned X, Y, and Z things that are the things you need that are important to you want to get back to. I think we got some ways to do it, but it's going to take some commitment from both of us. What can we do to help that? And then ideally working on it.
One of my favorite questions. Oh, sorry. I was just going to say one of my favorite questions to ask is, how can I help you change your exercise program to be something that you feel like you can accomplish no problem, right? Because maybe somebody thinks that they can do it on day one, and then they come back on day 10 and like, man, I had the bar set too high. That's not something I can do. And you just ask like, hey, how can I help you make this more doable for you, right? What can we do? What is your feedback? And then again, they're giving you the feedback. They've already done a little experimentation, and they're like, that thing that I thought was going to work isn't going to work, and here's why. Let's figure out how we can work around that, right?
Yeah. No, I like that. I think that's a great question. And again, you'll find ways as clinicians of ways you can start posing questions in non-threatening manners that show you care, and that show you're taking that person's unique context into account. People value that. And I think if you can make that a regular part of your conversations, and this are things like we said that we're kind of hammering home into our mentees and our mentorship and coaching program. But the more you can start getting these, I don't even want to say non-specifics, but some of these kind of soft skills dialed in, because we get so focused on these highly technical. I'm not saying you just be garbage with how you perform techniques. Hopefully you've understood, as we've talked about neurodynamics over the last bit, that we're pretty big on doing them well and consistent and repeatable and methodical ways. But if you miss the whole ability to communicate it well to a patient and be able to get a patient on board and to get a patient compliant and adherent, it doesn't matter how good technically you are. It just doesn't. Anything else you feel like you want to speak to about dosing, Jarod, as we've circled around a little bit, as we always do, but anything else you feel like we need to be discussing?
Yeah, I was just thinking, like, we've talked a lot about cognition targeted exercise and engagement and adherence and finding a dose that works for patients. But I would just say, in general, with neurodynamics, my thought process on that is that I'm not trying to build strength. I'm not trying to build endurance. I'm not trying to build power. I'm not trying to hypertrophy nerves or anything like that. I'm looking for increasing a nerve's capacity to undergo a certain amount of mechanical stress. And to me, that's, graded, not graded exposure, but graded activity. And nerves, luckily, are pretty plastic, right? They change pretty quickly. So in my mind, I'm looking to change the sensitivity of the neural pathway through repeated exposure to a load. So in my mind, that's something that I want to do with more frequency and less intensity, right? So if I'm looking to get somebody's neural tissue more tolerant to a certain amount of mechanical stress, I personally dose very small amounts of neural loading frequently throughout the day, where it takes them 10 seconds. It typically takes a patient 10 seconds to do, their exercise, whether it's a median nerve glide or whether it's a seated, kind of slump nerve glide or whatever you want to call it. I don't care what you call it, but it's little tiny small movement snacks frequently throughout the day. So you're repeatedly getting an exposure to that of mechanical load of specific tensioning to that neural tissue in a way that doesn't exacerbate it, that doesn't piss it off. But it regularly comes back to that neural tissue and says, hey, you need to be used to this. Hey, you need to be used to this. Hey, here's a little bit of load. Hey, here's a bit of load. And then we go based off of kind of the test retest over from one visit to the next. Okay, you did it this many times and it didn't bother you at all, didn't exacerbate your symptoms. How about we add in 2 more reps or 3 more reps every single time you do that exercise? So we've increased the volume now a bit, and you're going to see if that does anything. And if that doesn't, exacerbate things, like, okay, let's increase the volume again. Okay, that doesn't do anything. Hey, now let's try and increase in intensity. I want you to stretch it even a little bit harder. Don't change the volume. Maybe even notch down just a little bit on how many reps you do and stretch it harder and just a little bit harder and see what that does, right? So this is how you can kind of play with that dosing in a test retest from one visit to the next visit type of way, where you're looking for their response. You're gradually building volume, you're gradually building intensity, and you're doing it in a way that, at least in my mind, from understanding what I know about neuroplasticity and about response to exposure for the nervous system, a frequency type approach seems to be a little bit more effective for task learning and skill learning and neuroplastic changes than, hey, let's do this once a day or whatever it is. I would rather have them come back to it repeatedly. And I don't know if you think similarly or different than that, Mark.
No, I would definitely think, frequency, just to kind of expose to loads that can give it a frequent little nudge into it versus, big long sessions that are really getting after it. And I think there's a lot more risk, I guess, of aggravating when you're doing, one blast session versus small movement snacks and then, slow, methodical, thoughtful progressions. And then if you can get neurodynamics to start looking like valued activities, like, reaching overhead, doing things where, some of these movements are starting to look like the things that they're telling you they're not able to do, striding with walking, different things like that. You can get creative with neurodynamics. I think there's this belief that only happens in the perfect neurodynamic position you learn in school. Anytime you reach behind you, neurodynamics. Anytime you reach overhead, neurodynamics. Anytime you stretch your leg out to stride, neurodynamics. There needs to be tolerance to neurodynamic loads in a majority of movements we do. Other things I would say is just, for some of our patients, fibromyalgia, for instance, just make sure you're looking big picture on what sensitizes their system. Most of those patients, I shouldn't say most because it's nuanced, of course, but a lot of those patients are sensitive with most neurodynamics because they have a system-wide sensitivity that's, so that's where you zoom out and you make sure lifestyle medicine pieces are in place and you're doing things and you're plugging people into that. And oftentimes when they come in after a horrible night's sleep, you can do some test retest and look how bad these neurodynamics look after that. I wouldn't say that to a patient, but can you see how it's different now that we're having a really cranky, didn't sleep or, whatever, huge stress sometimes. I'll do that with patients and you can see the system's different. And I say, this is where I just want to connect the dots with you that, what you're going through outside of these walls impacts what happens inside these walls and how your body demonstrates movement and how comfortable movement can be. And I tell people, medicine has tried to break those two things apart. I'm here to put those two things together so it makes sense to you and you can look big picture at instead of trying to treat a tree in a sick forest, you're treating your forest. And I have those dialogues with people regularly and I think people start seeing how, oh God, this stuff makes sense now. And then you alter doses based on where their life's at. Maybe they're in a massively underslept, stressed situation where you might need to back down dose and back down what you're asking of a patient just to kind of respect where they're at currently in that period of their life. And you say, hey, we'll get back on the horse of frequency and stuff, but let's make sure you're still giving reasons for change, but maybe we need to be mindful of where you're at right now. And again, it's a nuanced thing where you can see some patients might be able to continue on and soldier on, and we don't want to make things become stressed, life contingent, where we start tucking tail and running away from those things. But it's a nuance, like, hey, we don't want to push the door down when the system's buffer is kind of where they have minimal buffer to start getting into stuff where they have some ways to thoughtfully respond, and maybe they do some purposeful recovery stuff that they're mixing in with some of the other things. But yeah, anything else you'd throw at that, Jarod?
No, man, I think you nailed it. I like the fact that you brought up making neurodynamic exercises or exposures real life, because that's ultimately what we're trying to get back to is real life. And it is so important to recognize that the way each individual person responds to those type of loads is going to be different. And especially you brought up people with fibromyalgia, or that kind of that complex chronic overlapping pain conditions cohort of people who tend to just have a little bit more reactive of a system. Your dosing is going to need to look different for them, and that's where this patient specific dosing comes in, and where the cognitively targeted dosing comes in. So you can't just apply the same dosing scheme to everybody, and you can't use the same dosing scheme for each person at at different points in their recovery. Yeah, no, definitely. So this is exactly the conversations we have with our coaching clients and our clinician folks that are in our coaching and mentorship program. One of the things that Jarod and I have discussed with this is that the con ed world of weekend courses getting jacked up, nothing wrong with that. Online courses, nothing wrong with that. But why not make the clinic your biggest classroom, where you're learning with the people you're currently struggling with? And that's why we designed our Supercharged coaching program, just because that's been the most valuable thing for me, is where I've gotten my problems worked on with a clinician currently to give me some thoughts, some ideas, some ways to start applying this stuff in practice. And I wish I would have had it earlier in my career, because I think it would have saved me a lot of blood, sweat, and tears and nearly quitting the profession. For someone to help me just kind of weed through all the crap that you hear on social media and all the things we should and shouldn't be doing. Well, how does it fit with the unique person in front of you? How do you start incorporating these things, having the dialogues? How do you get coached? How do you learn to have some of these conversations, bring in cognition targeted exercises? Those are all the things we talk about in our coaching program. So if it's something you're looking for, that you're just hungry and you're ready to just take your practice up, or maybe you're a new grad who's like, hey, I need to get ready to hit the clinic and be good early, because DPT school gets you safe. It's doesn't get you where you need to be, and that's because the clinic is what's going to be your classroom. So why not make it the best classroom possible for yourself, so you can teach and or you can get taught and learn and grow at a more rapid pace than if you're just kind of throwing mud at the wall and hoping things are working and not knowing what's happening with what, and not having a purposeful process. So jump on modernpaincare.com/supercharged, and you can jump on a call with Jarod and I. Will see where you're at in your practice, see where your goals are, and if it looks like it might be a good fit, we'll talk about what working with us might look like. We're accepting a limited amount of folks, because we don't want a big, massive program where we're not able to give the one-on-one attention that folks deserve. But we've really enjoyed it, and hope you check it out. So check it out online. So with that said, I'm going to leave you guys there, and hope you've enjoyed the episodes. We'd love to hear from you. If you want to message us on social media, Instagram, Facebook, or wherever you are at, that would help us just knowing if these episodes are bringing value to you, or if there's anything else you want us to talk about, we're game to do it. But until next time, we'll see you later.